Hi, folks. I'm Ronnie Zeiger from our health team, and it's a great pleasure for me to introduce Sanjay Gupta, who probably needs very little introduction.
Hello.
A couple of quick notes. First, an acknowledgement to Lauren Dolmeyer, who helped orchestrate this, and this talk is in honor of Michelle Dolmeyer. And just a couple of notes about Sanjay, because I don't get to do this too often. So he's not a rocket scientist, but he is a brain surgeon, and he's on faculty at Emory University. You probably know that he's the chief medical correspondent for CNN, winner of multiple Emmys there. Close to many of our hearts, he both professionally and personally has done a lot in and for the country of Haiti and continues to do so. Actually, last time I saw Sanjay was at a conference where he spoke remotely from Haiti. He was rumored to be next in line for the U.S. Surgeon General until he removed his hat removed his name from the hat. And most important, and what I'm most impressed by, is that People magazine named Sanjay one of the sexiest men alive.
Really? That gets the applause line? It's like your credibility is completely taken away after that. All these things you do in your life, then sexy man thing. Thank you very much for having me, Ronnie. Thank you for that. I was really looking forward to coming here because I think things like this really represent the best of citizen scholarship. People just getting together and swapping ideas and chatting. So I love this sort of thing. Also, it's fun to be in front of real people. I don't get to do that very often. Usually we're in a quiet studio somewhere where it's just a camera and you and a couple of guys walking around with tool belts and duct tape and telling you when you're live and when you're not. And you wear this earpiece in your ear. I don't know if you've seen this when you're watching a reporter in the field. They got this earpiece in, and people are talking to you while you're reporting, which can be very distracting. And when I first started doing this about 8 or 9 years ago, they would always be talking to me, telling me how they wanted me to act. And usually it was like, why do you look so serious? Or something like that, in the middle of when I'm trying to do a report, followed by a few minutes later, what are you grinning at? Or something. So lots of advice that they certainly give you. I was excited to be here. I was excited to talk about sort of my melding of a couple of careers of medicine and media, something that I've been doing for just over 8 years now. I care deeply about this idea of being able to transmit medical knowledge out in all sorts of different ways. I think that's what sort of drove me to the life that I now lead. I'm a neurosurgeon. I practice at a university. I used to be a speechwriter for a while in the late 90s, talking a lot about healthcare issues, writing those at the White House. And I realized that there's a lot of similarities between medicine and media, I think, back then. I think in both, you obviously have to do a lot of reading and homework. I probably do more reading and homework than I've ever done in my life, even counting medical school and my training. I think with both, media and medicine, if you do it right, you can really, truly help the quality of people's lives. And I think with both, you have credibility as their most crucial factor. If you lose your credibility in any way, you've lost a lot. You have to know your audience. I think as a doctor, you certainly have to know a lot about your patients. As a media person, you have to know who your audience is as well. And I've learned this lesson in lots of different ways. One time I was actually, back when I was a fellow in neurosurgery, I was on call once, and this woman had been jumping on a trampoline. And she was playing with her kids, about 40 years old. She was jumping on a trampoline. She fell off the trampoline and felt a pop in her neck. And we ended up getting these scans when she came into the emergency room where I was on call. And you can't tell, but she has a little broken bone right at the top of her neck there. And I talked to her for a while, sort of told her what I thought would be the best thing to do. And I decided I'd put her in one of these halo devices, which is a device that looks like this, sort of allow the neck to be immobilized and let that bone heal. And she flew right through it. She had no problems. And I went out to go talk to her family shortly thereafter. And I was describing this whole thing to her husband and her 2 kids. And her husband was just understandably, he was very anxious the whole time I was talking to him several years ago. And I said, so she has a halo. I put it on, the whole device. And he's just looking at me the whole time. And then finally I finished, he looked at me and he goes, yeah, but doctor, you look so young. Have you ever done this before? And I said, well, no, but I did stay in a Holiday Inn Express last night. He obviously hadn't seen that commercial, so his kids laughed. But you really do have to know your audience when you're talking about all kinds of things. I was particularly delighted to be here, in part because I think it's true that more people probably turn now to Google than to their own doctors. I had this slide made. It was funny because, first of all, that font is really hard to find, I found. We had the Dr. Google. Yeah, I'm not sure if it's proprietary and I'm in trouble, but certainly a lot of people do turn to Google more so than their own doctors. And I think the same qualities that I was just describing in terms of what we have to do in the media, I think do apply to Google as well in terms of the quality and the credibility of the content you all provide. And I'm also amazed by something else that Google can really help facilitate, and it's this idea that there's lots of ideas out there. Right now there's lots of smart ideas in somebody's head, but the whole process to take it from just a smart idea to actually being something that can be of benefit to people, that can take a staggeringly long time. And I think that if you can somehow speed up that process using all of you, using people at large in society to say that we think this is an important medical development, here's how we might apply it, I think that's sort of the way that we're headed. And I can't help but think that non-traditional ways, such as Google, such as the media, is really going to help make that happen. As a doc, I've been fascinated for a long time about what we know and what we still need to learn. And I think there's a lot of dogma in medicine, perhaps more so than a lot of other fields, because of the nature of medicine. So when I was thinking about writing this book called Cheating Death, I was really sort of excited by this idea that I'm not sure what we really know about death as of yet. Woody Allen said this: "I don't want to achieve immortality through my work. I want to achieve it through not dying," which I think how a lot of people feel. What is immortality specifically? I remember when I was a third-year medical student, I was on call once, and this patient came in who I remember really well because he was about the same age as me at the time. And he had been in a car accident. And I remember he came in, he had all sorts of different injuries, and all these doctors were working on him, the neurosurgeons, the orthopedic surgeons, the general surgeons. They were all trying to save him. And then at some point, they basically stopped. And he didn't survive. And I remember thinking, that's it. That's just how it works. At the end of this whole triage, at the end of this whole effort to try and save his life, at some point, they just had to stop. And it got me thinking, what is death? Is it really this binary process, sort of on and off? And what I realized when I was talking to lots of smart people around the world, that death really isn't an event at all. It's this process that can be interrupted and even reversed. So if you think of that sort of as the thesis, then it really opens up a bunch of different doors in terms of how you approach medical care as a whole. This is another thing that I thought was really interesting, that we are still inconsistent around the country and certainly around the world in how we declare someone dead. How do we even know for sure that someone is dead? How do we know that the process is no longer reversible? If someone has what's known as a do not resuscitate order in their chart, they are more likely to die. Because doctors, nurses, every decision that's made from that point onward is no longer focused on prolonging life. So lots of these micro decisions start to change if someone has said, I no longer want to be resuscitated. And so that all leads us back to this patient that I saw as a third-year medical student. Death may be described as the time when doctors quit. So what is it that we can do differently in the medical establishment? And what is it that we can do different as doctors individually? And what I realized is that a lot of it is simply about buying time. If you can buy minutes, you can buy hours, you can buy days on behalf of your patients, a lot of them are going to be much more likely to recover. And that was really what sort of prompted this book. It got me started on this journey that really, over 2 years, took me all over the world. I was in brain tumor labs at Duke, fetal surgery labs in Boston. I was in Tromsø, Norway. I was in Okinawa, Japan, really trying to learn how people approach life and how people approach the end of life in different ways. And what I realized is that it's different in lots of different places, but some of the strategies that are used are remarkably simple, yet not widely applied. So, a simple question, for people in this room even, if someone were to collapse right now in the room, would you know what to do? Would you know precisely how to save that person's life? We know that if a bystander jumps in and helps, the likelihood of someone surviving increases exponentially. But we also know that the likelihood of a bystander actually jumping in and helping is really small, staggeringly small, despite the fact that people say they want to help. They want to try and do right by the person that's sitting next to them or in the same room, but too often they don't. CPR, it's something that people sort of generally know about. Maybe you took a course or something. obviously trying to pump the heart, do mouth-to-mouth resuscitation. But when you ask people why they did not help somebody who had collapsed in front of them, oftentimes it is that sort of feeling awkward or unsure still about the mouth-to-mouth resuscitation component of it, which I thought was really interesting because it's this life-saving act potentially, but because of this one particular part of the life-saving act, about 2 to 3% only of people actually get in and try and save someone's life. So here goes this whole process now. So you have a problem. You can save someone's life by doing this, but too often people don't. So what if you did not do the mouth-to-mouth component? What would change? Could you possibly save people's lives more easily? And that gets us back to this idea that death is a process. The answer is yes, but death is a process, and so is, in this case, a cardiac arrest, one of the most common causes of death in this country. A process. You have an electrical phase to the process, you have a circulatory phase to the process, and you have a metabolic phase to the process. Now, I don't want you to get too hung up on the terms, and I'm going to explain what that means, but during the electrical phase, when someone's heart is starting to not work properly, the heart still has electricity in it. It's still going to be pumping. It's just too uncoordinated to actually be of any meaning. So the blood's not actually moving through the body. It's that period lasts usually just several minutes long, and it's during that period that someone can apply a defibrillator and actually shock that heart back into a normal rhythm. Now I want to warn you ahead of time. Some of the images I'm going to show you today are somewhat graphic, and you know, this one, for example, this one I'm about to show you is, and if you have any problems with it, I'll just tell you ahead of time before each of those slides. But just take a look at this. This is actually an open heart operation in someone who's just gone into cardiac arrest. Look at the heart, look how it's quivering. Look at the bottom right screen. That's what the EKG looks like. An electrical shock was just applied there, and the heart goes back into a normal rhythm. Look at the bottom right of the screen, and you got a normal rhythm again. That's what the EKG should look like. So again, that's the heart sort of beating, quivering. That heart rate is not doing anything. It's not pumping any effective blood. A shock there, 2 paddles you see, and that gets the patient back into a normal rhythm. The paddles come out. That's the electrical phase. That's the first few minutes. If you can apply a shock during that time, you can literally save someone's life, just like you see there. The last phase is what's called the metabolic phase. That's the final phase when someone's cells in their body are starting to die because they're not getting enough oxygen to the body. And as a result, those cells just simply cannot continue to metabolize. What the thing that I learned was, and I think the most fascinating part of this whole thing, is that we actually right now, or someone who suddenly collapsed, we have plenty of oxygen in our bodies, a lot more than you might think. So as a result, the mouth-to-mouth resuscitation part of CPR is really not necessary. You have oxygen, you have the blood. The key more than anything else is to move that oxygenated blood through the body. I was doing this documentary, and I was curious. I mean, how much oxygen, how long could I hold my breath, for example? How much oxygen was really in my body? And you have these people who can hold their breath for an extraordinary long time. You know, Tanya Streeter, for example, is the world's free diving champion, and she can hold her breath for 6.5 minutes, for example. I was curious, how does she do that? So I decided to go visit with her. She is the free diving champion of the world, and she basically took me into her pool here and started to show me how to do it.
Remember the complete relaxation in your muscles that you're using, especially in your head and your neck. If you're clenching your jaw, just relax that whole area. It's perfect. You look really relaxed. I don't want you to think about time, and I'm not going to tell you time. Just listen to your body. Any signals that you receive, just make an assessment of what it feels like. Consciously relax.
I didn't play out the whole clip, but I was able to hold my breath for close to 3 minutes, which was something I never thought I'd be able to do. But literally within just about an hour of training, she was able to show me how to do that. And I thought it was remarkable. The way that she holds her breath for so long is she actually takes what's known as a pulse oximeter, which tells you exactly how much oxygen is in your blood, and she puts her finger above the water and watches the numbers, as she's holding her breath. And she can hold her breath 6.5 minutes, and the number really will go down from about 100% to 98% only. So you got plenty of oxygen in your blood, and this was just proof of that. So if you think about these phases of someone actually going into cardiac arrest again, and sort of go through them, it makes obvious something that we don't do nearly enough anywhere in the world. The heart may have some electrical activity in the first few minutes, but that's ineffective. You actually have plenty of oxygen in the body during a cardiac arrest. So the key, more than anything else, is to move that oxygen around using chest compressions. Do chest compressions, no mouth-to-mouth. In fact, don't stop doing chest compressions for anything. There was, in a couple of states in the country, they've started implementing this to try and see what kind of results they would get. How would it change in terms of the likelihood of someone surviving? Arizona is one of those states, and here's a 911 tape from that state.
Fire department, what's the address?
No, my husband's not responded.
Okay, what's your address?
This is a call to 911 in Scottsdale, Arizona.
Ma'am.
A 53-year-old man is in cardiac arrest, and that's his wife on the phone.
Okay, is he breathing? Okay, listen to me. Someone needs to start CPR. Do you have anyone there that can do CPR? Someone needs to...
Now listen carefully to the dispatcher.
You need to put him on his back. Okay, put the heel of your hand on his breastbone in the center of his chest. Okay.
And notice what you don't hear.
And then you need to put your other hand on top and interlock your fingers.
There was nothing in there about breaths. There was nothing about giving breaths.
I need to press straight down into his chest, okay?
Okay.
You need to go quick, okay? Start counting for me.
Okay, 1, 2,
3.
You see, it's all about compressing the chest. And until just recently, that would have been unthinkable. But it does work. And here's why.
Again, you heard nothing about actually giving mouth-to-mouth resuscitation, which was absolutely the standard of care even up till last year. Just recently, the American Heart Association is starting to change their guidelines. But what they found in Arizona and in Wisconsin, the other state they did this, is that the likelihood of survival now in those states of someone who were to suddenly collapse went up 400% as a result of the fact that they don't do something that they used to do. So a lot more lives being saved. This is an example, I think, of how medicine moves. The science is explained, the technique is easier, and then you start to get behavioral changes. When you talk about cheating death, when you talk about trying to increase survival in patients who you didn't think you could save, this is an example. Buying time, in this case, buying minutes. Buying hours is really another part of this. How do you buy even a longer time than that? Someone has been resuscitated. Now they're on the way to the hospital. And the way to really think about what's happened to them is they haven't got enough blood flow to their brain for some time. So you really have two options. You can try to increase the amount of blood flowing to their brain, which is what they're doing with the CPR, or you can try to decrease the amount of blood that the brain is demanding. And that's sort of the second part of this. Is there a way to somehow change the metabolic demands of the body in that immediate situation? I had heard about this woman in Norway who is named Anna Bagenholm. She was a skier who got trapped once underneath this icy river. And without knowing it at the time, she couldn't have known it at the time, but she became sort of the model for how hypothermia might change the way that we approach medical care. If you could somehow put someone into a sort of deep freeze state, could you change the way that we're going to actually be able to care for them? As part of this whole thing, she asked me if I would actually jump into the similar sort of icy water that she had been in for a period of time to just get an idea of what it felt like, and I did. This is how we started.
Normal body temperature is 98.6 degrees. Mine, 95. I was dizzy, nauseated, a little confused. Below 85, and your heart's in trouble. Remember, Anna Bagenholm's temperature was 56 degrees. Anna was fresh out of medical school when she chose to live here in Narvik. It's a skier's paradise. In May of 1999, she was going down the steep gully with two friends and fellow doctors in training, Marie Falkenberg and Torvin Nasheim.
The problem is that when we come down to this frozen gully, it's a bit steep, so I hit some steps, and then I turned on my back and started to slide down the ice on my back. And then Torvin, he was a bit lower, and Marie was a bit higher, and then they kind of got rid of their equipment and ran to me, because what I actually did was that I kind of hit a hole in the ice so that the head went under
What happened was she landed upside down, with her head stuck underwater between a rock and a thick shelf of ice. In fact, this is the exact spot where this all happened. Two of the men involved in Anna's rescue showed us.
She was where the water was is now most eager, over the cliffs here.
You can only imagine the desperation her friends must have felt as the moments started to tick by. She struggled for a while, and then she stopped. It took more than an hour and a shovel to free Anna from the ice. Torvin and Marie immediately started CPR. As the clock was ticking, a helicopter flew Anna to the University Hospital of North Norway. It's an hour away in Tromsø, where she was taken straight to the operating room.
She has completely dilated pupils. She is ashy, waxy white. She's wet. She's ice cold when I touch her skin, and she looks absolutely dead. This is the double-edged sword again. The cold was protecting her brain. It was stopping her heart, but it was protecting her brain. The brain was so cold that it did not need any oxygen.
And the doctors began to slowly rewarm Anna's blood. Now, take a look at this. It's Anna's heart.
Just saw some little shivering, and suddenly, it contracted. And there was a pause, and a second contraction. Everybody goes like that, and we had really tearful eyes, all of us, because it was a moment of victory.
Everybody that we've talked to, they talk about that moment.
Yeah, I know.
So the heart's. Yep. Let's see here. I'm gonna escape that for a sec. So Anna really teaches us the concepts of hypothermia, this idea that you can buy hours. She was 9 hours without a heartbeat. She had dilated pupils. She had all the signs of death. In fact, in most hospitals around the world, she would have been declared dead. But the point that Mads Gilbert, who's the doctor that was taking care of her, was trying to make was that when someone is that cold, 56 degrees, they've essentially shut down all of their bodily processes, and they can survive. She went on to actually become a doctor in the very hospital where she was once thought to be dead. So she made a full recovery. And I think she's really, she's been the model for how we're starting to implement hypothermia at hospitals now all over the world. That's about buying hours. One of the things that people are starting to look to now in the future is this idea of buying days. Could you buy a patient days? Someone who is near death, perhaps a soldier who's been shot overseas, someone who's caught in an avalanche or a near drowning sort of experience, is there a way to buy them days? And the whole idea of suspended animation is really coming into the forefront of science. And I find this really fascinating. Mark Roth, who's the guy on the screen right there, he's a bona fide genius, and he's been looking into this some time now. But what he's basically been able to do is prove this, that right now we're all breathing in about 21% oxygen. That's what air is, 21% oxygen. If I was to suddenly decrease it to about 2% oxygen, we would probably die. But the irony is that if I was actually to completely take away all the oxygen altogether, you might actually be able to survive. Because as essential as oxygen is to actually our bodily processes, it actually is essential for actually creating the death pathways as well. And that's what Mark Roth has been able to show in animals. Now he's starting to do the same thing in mammals, and he believes over time we're going to be able to do the same thing in humans. There's two sort of important ingredients here. You take away all the oxygen, and this way you give somebody some sort of chemical that blocks all the oxygen receptors in their body, and now the cells will die because they don't have some sort of fuel, so you got to provide a fuel source as well. That's exactly what they're hoping to try in Afghanistan and Iraq, where they actually can give a medicine that's in a syringe, two substances at the same time. One is a substance, again, that blocks all of the oxygen receptors, and the other is just a bunch of ketone bodies to sort of keep the body preserved during the time. Person gets shot, they're essentially suspended with the shot of this stuff. They can be put on a helicopter, they can be flown to wherever around the world, they can be put on an operating room table, everyone ready to go to work, and they reanimate, and they start taking care of the patient. It sounds like the stuff of science fiction, but it's one of the things that I found is starting to happen, at least in animals, and I hope within humans, within the next few years. With Cheating Death, the book, you know, it was interesting because there was a lot of stuff that was sort of fascinating from a cutting-edge science standpoint, and there was a lot of stuff that was sort of non-intuitive as well. This idea, for example, that you know, being optimistic, being hopeful, somehow changes your outcomes. For a long time, that was sort of thought to be anecdotal, subjective at best, and now it's really fallen into clear mainstream science. The idea that someone wants to live changes everything about their bodies, changes the number of endorphins they produce, changes what's known as tumor necrosis factor, helps them fight tumors better, it modulates their blood pressure, the simple act of optimism. But also, it seems to change the behavior of all the people that are caring for them as well. Not only their family members, but their doctors and nurses. If someone really shows a true will to live, it seems to help in terms of all the micro decisions those healthcare providers make in terms of trying to save that person's life. I get to think about a lot of these issues a lot when I was writing the book and in the job that I do in the media as well. But a lot of my time is spent as a doctor, taking care of patients one by one. And it's funny, being a neurosurgeon who also does this sort of work, I sort of liken it to the fact that most of my life, most of my training, I spent literally looking under a microscope, doing the operations that I do. And in this job, I get to take a more global look, a more telescopic look at the things that I really enjoy. But my first love has always been neurosurgery. I've always just enjoyed the practice. I enjoyed taking care of patients one-on-one. And one of the things that I really wanted to talk about today was the types of operations that are being done on the front line as well. One of the operations that we do in neurosurgery is aneurysm surgery. It's actually taking care of what are known as little blood blisters on blood vessels in the brain. Sometimes these blood blisters can rupture, and that's what causes problems. Trying to identify patients who have aneurysms ahead of time has been one of the real challenges in neurosurgery. Estimates say that between 1% and 2% of the population is walking around with an aneurysm that is unruptured. How to know who those people are? Should you screen for them? We haven't arrived at any really good answers to that question yet. So most of the patients we see, their aneurysms have already ruptured, and that's the first time we see them as a neurosurgeon. So I want to show you some images here. Again, some of them might be a little bit graphic, but I'll give you really good explainers as to what you're looking at. Typically, when someone has what's known as an aneurysmal rupture or subarachnoid hemorrhage, they sort of feel what's known as a thunderclap headache. So it really feels like someone almost hit them in the back of the head, and it's just a sudden onset headache. It's one of the clear signs of this. And the type of CAT scan that they would get probably in the emergency room would look something like this. And you see the brain there, but you also see all the white, which is the blood. And when you think about blood from this type of rupture, it's not a discrete blood somewhere in the brain. This is blood that sort of is, think of the brain as a sponge. The blood has sort of infiltrated that sponge. So an operation to remove the blood really is not something that can or should be done. The goal really is to stop any more bleeding from occurring. Next image is going to be a little bit graphic, but you're going to take a look at what that blood looks like in real life. That's a little bit of it there. That's the underside of the brain. And all the dark stuff is clotted blood in someone who's had a subarachnoid hemorrhage. Now, this scan here, it's sort of an interesting picture. This is what we call a 3D reconstruction of an angiogram. And you can sort of get an idea, but all the lines in there are blood vessels, and then you have a big bubble at the top. And that's what the aneurysm really looks like. The aneurysmal wall has become a little bit thin, and that's why it's allowed to bulge out like that. And because it's thin, it can also pop or rupture, causing some of the images that you just saw. This next image is basically what the angiogram looks like, and you might be able to make sense of this now. This is a complicated image, but the one on your left is the one that shows the aneurysm. You can see that at the top. And the one on the right is with the aneurysm gone. That's after what's known as an aneurysm clipping has been performed. So you take a look, you see those aneurysms gone. The type of operation usually involves a clip that looks something like this. This is a very magnified image, but that's an aneurysm clip. You take those little prongs and you put it around that bubble and you stop any more blood from getting into it. It's really as simple and as complicated as that. That's called an aneurysm clipping. This is sort of the beginning of an operation here. So you're actually seeing this is the skull. You're seeing the muscle being removed. You see some of the bone here. And it's really, this is the first part of any kind of operation in someone who's had an aneurysm or a tumor or any kind of operation of the brain. This next image, again, going to be a little bit more graphic, but this is going to see with the outer layer of the brain removed. This is called the dura, and you're actually looking at the brain now. That's what it looks like. And trying to actually find the aneurysm and all of that, that can sometimes be the real challenge. But this is what any beginning of the operation sort of looks like. Now, I'm going to show you just a brief video from an operation I did just a couple of weeks ago, actually trying to clip an aneurysm. You're going to be able to make better sense of it now, given all the images you've just seen. So take a look. You can see the blood vessels sort of to the side there. You can probably make out what the aneurysm is right away. A little bit closer now. And that's the clip going in. You can see it coming out of the screen there. I picked a curved clip here, and that is going to basically sit on that bubble and try and exclude that aneurysm from the rest of the blood supply. I usually close these clips on a 10 count. You do make these micro movements to make sure you got it all without stopping any of the blood flow to any of the other blood vessels in the area. And you want to make sure the aneurysm doesn't rupture here. It's probably one of the most critical parts of the operation, one that really gets your heart going as a surgeon too. But that's basically it. You've just seen an aneurysm clip applying. We inject some dye and look at this under a special microscope. And you can see the clip right in the middle of the screen, and you can see that the aneurysm is now gone. Show you one more really quickly here. This is a slightly more complicated one, and it gives you a little bit of an idea of just how challenging these can be, but lots of blood vessels sitting on top of what is obviously an aneurysm underneath that. You can see the calcified aneurysm underneath, and see how the blood vessels can sometimes really stick to the aneurysm, and again, any of these can potentially have bleeding and possibly cause problems, so you really got to separate that. Basically, you're looking at magnification about 30 times, so these are really small movements to try and separate out that aneurysm. And in this aneurysm, it was so large and it had so much calcium, which is the yellow in it, subsequently took 4 clips to sort of get that aneurysm clipped. But again, that excludes the blood supply. This is a little bit of a look at, obviously really forefront, cutting-edge medicine with some of the bigger ideas that I think we're all talking about in medicine in terms of how to prolong life and how to allow patients in large numbers to cheat death. Sometimes it can be really simple. Simply using your 2 hands and doing chest compressions, just like that video showed, not doing mouth-to-mouth. Again, 400% increase in survival. Any of you could save a life based on that alone. To aneurysm surgery, which is obviously something that's happening at the forefront right now. It's likely to change over the next several years. But it's a little idea of what I've been up to the last couple of years, and I want to thank you again. Thanks, Ronnie, for having me, and happy to take any of your questions. But thanks so much. Appreciate it.
I have a question for you. After the aneurysm is clipped, do the clips, they stay in, or how does that work? What's like the part that afterwards?
Yeah, they stay in. These are titanium clips, and so they don't set off metal detectors or anything, although you can't get an MRI scan after this because the MRI is a big magnet. But yeah, the aneurysm probably over time will just clot off and really not be a problem anymore after the clip is applied, but it's a whole other operation to go back and take it out, so we just leave them in.
Hi, I wanted to thank you for coming. It's an honor having you here at Google.
Thank you.
And I wanted to ask you a question regarding the chest compression and the ventricular fibrillation or arrhythmia. If you are suffering from that, is it such that just the chest compression will cause the arrhythmia to stop and that will be sufficient, or will you need to use an electrical kind of stimulation like you showed in the video?
Yeah, I'm glad you asked that. I mean, before you do anything, if someone collapses, you should always call 911. Because they can bring a defibrillator. That's going to be important to actually get the heart back into a normal rhythm. All you're doing with the chest compressions is taking oxygenated blood. Again, which you have plenty of. We all have plenty of, several minutes, 10 to 15, maybe even 20 minutes of oxygenated blood, and just moving it throughout the body, making sure the brain is getting enough, making sure the heart itself is getting enough oxygenated blood as well. So that's all you're doing with your hands. You're basically a mechanical heart pump until someone can shock that heart back into a rhythm or give medicines to get that heart back into a normal rhythm or something. So that's it.
All right, thank you.
Hi, so earlier on one of your slides you describe death as when doctors quit trying. So I was wondering what your personal standards are for when you quit trying, and if that's quantifiable or not, and how often you let your patients decide when that is.
Well, you know, a lot of times it's the patients' families, because the patients are so sick. You know, at some point there's a lot of conversations with the families. You know, the thing about it is, and part of the reason I had that slide in there, part of the reason I wrote the whole book is because there isn't a consistent guideline. I think you could find, you know, one of the patients that we profiled in the documentary, he literally, they had 9 separate defibrillation attempts on him before they got him back, and he's doing fine. Some people might stop at 4, some people might stop at 5. Anna Bagenholm became so well known in the medical world because she came in essentially looking like she was dead. She had pupils that were dilated, which usually is a sign that the brain is no longer functioning. And I think, like I said, I think most hospitals around the world, they would have not tried anymore. I don't know. I mean, I don't think there is a consistent thing right now. Right now, it is sort of when doctors decide to quit. Whether it's a more chronic disease or whether it's a more acute situation, you'd like it to be more consistent, I think, around the country, around the world, but it's just not that way right now.
I guess I was trying to get more at what's your take on the vegetable status, or, you know, not like 4 times versus 7 times, but for you as a doctor, especially dealing with brains and stuff like that, when...
On vegetative status?
Yes.
Well, that's a different issue. I mean, that's not really about cheating death so much as it is about neurological recovery. And you know, I think that, you know, it depends. If someone's on a breathing machine, for example, versus not on a breathing machine, you know, patients can go into coma stimulation programs for a long time after a head injury. So, you know, I think in that situation, that really becomes much more of a family decision. Sometimes patients may deteriorate, they may develop pneumonia as a result of being bedridden for so long, but and that might take it into more of an acute situation. But you know, I think that's a little bit different than sort of an acute situation.
Thank you.
So Dr. Gupta, again, thanks again for speaking with us today. I wanted to remind people that if you go to go/asksanjay, you can submit questions through Google Moderator as well. I had just a big...
You can?
Yeah, absolutely, and vote, and it'll be really awesome.
It's an internal link.
So I did have a question for you. One of the things that we really, you know, hold dear at Google is free and widespread information access, and you know, you play a big role in that with your role with your job in the media. What's the next step for increased information access in the health sphere that the media or technology can do?
The next step. You know, it's funny. Ronnie and I were just talking about this beforehand, and you know, I don't know. I mean, I got my own ideas on this, but I think that, you know, it's a really interesting balance between having the best, you know, peer-reviewed content, knowledge, information available to people versus things that are happening right now that may somehow be of benefit to large numbers. I was saying to someone the other day that, you know, at CNN, for example, or at CBS where I work as well, if you have a particular story that, for example, is about Alzheimer's disease, but the science is pretty young, it's maybe just showing some benefit, a new treatment showing benefit in animals, hardly any television organization is going to run that story because it just seems too young. It's not developed enough. On the other hand, if your mom or dad is developing memory problems, you as a consumer want to know everything. You want to know about that study. You want to know about any possible new treatments that are sort of coming down the pipe. So how do you somehow balance this idea that you want really credible, high-quality content and make it more instantly accessible? And I think ultimately it's probably going to be this idea that, you know, there's a lot of very smart people who both work inside and outside the healthcare profession that are really going to drive that train. And that's, you know, what I said at the beginning of this talk. I think Google in particular probably will be a large part of that, because even being able to quantify what people are searching for at any given time, seeing where they're going and seeing what types of health topics are becoming more commonly searched, I think can change the way we start to transmit knowledge. So, I don't know. I think it's exciting. I think that we have this talk in 5 years, and it might be totally different, which I find really, really fun, exciting.
Thank you.
All right, Mike, my question's kind of along the same lines. I'm a bit curious about what you feel in the sense that an average person going to a doctor and making recommendations based on ads they've seen on TV for drug companies, and it just seems like that's occurring more and more, and what your view is of just the mass marketing campaign that drug companies take to try to influence patients instead of doctors for certain drugs.
The drug company, I'm sorry, what was the last part?
The mass marketing campaigns drug companies use to influence patients instead of doctors themselves for the use of certain drugs.
Yeah, you know, here's my view on this, really. I think for the most part, I'm a believer in information. I think more information is better. I think that sometimes that system doesn't work perfectly because sometimes people can get too much, they can feel overwhelmed, they feel like they have too many choices, options, they don't know in which direction to turn. So I think, you know, a couple of things. I think you got to make sure that the information that's being given by anybody, whatever the source is, has to be really high quality, credible content. And I think that goes for the drug companies as much as it goes for the media, as much as it goes for doctors' offices. That's got to be trustworthy content. And the other thing is I think you have to be able to recognize that consumers are going to want things faster probably than they ever have wanted before. And with health and medicine, I think that's probably the most important. I think different than, you know, in the media, different than political content that we do or even, you know, news about weather. I think with health and medicine, it is probably the most crucial. So I think the ship has sailed in terms of how people are already going to be getting their information. I think the key is to make it as credible, high quality as possible.
Dr. Gupta, thank you for coming and talking to us. First of all, I want to thank you for something else as well. Through your interviews with Dr. Henry Friedman at Duke University, I found additional information about brain cancer, which my mother recently was discovered with. So I just wanted to ask you, like, the kind of views you have presented here in Cheating Death, it's more about sudden kind of things, sudden events that somebody has. How do you manage care for, let's say, terminal cancer patients and those kind of things?
Well, you know, and you brought up Henry Friedman, who's a neuro-oncologist. Is that what you said, Henry Friedman? Yeah, he's a neuro-oncologist at Duke, and you know, he's pretty well known for taking care of patients who have what are known as glioblastomas, which is one of the most, one of the toughest tumors to treat, a tumor that we've not made great progress in over the last 50 years, really, in terms of survival. You know, I think a lot of it ultimately, you have these patients who are sort of long-term survivors of this tumor. And one of the things we did in the book was trying to figure out what ties those patients together, what makes them similar versus the patients who did not live longer than a year or 14 months, which is the average survival with this. And it really seemed to be a couple of things. One is that they were diagnosed early. So these were patients who basically went in at the first sign of some sort of symptom as opposed to waiting. And the second thing was that from a treatment standpoint, there's this sort of paradigm in medicine that if we don't know what the answer to a problem is, we're going to try one thing, see if it works. Try number two, see if it works. Try number three, see if it works. That's just how academic medicine moves. It is slow, and it's hardly ever beneficial to an individual patient unless you seem to seize upon the one thing that really worked. At Duke, and a few other places around the country, they realize that it really, with a tumor like that, it requires more of a kitchen sink approach, that they really have to try all sorts of different things at once. We'll figure out the science at some point, try and figure out what really worked out of all those things, but right now it's about trying to save somebody's life, prolong their life certainly, and that's why, you know, the longest known glioblastoma survivor in the country is about 14 years now, which is 14 times the average, and that's the sort of approach that he got, was much more the kitchen sink approach. So I think a lot of it is trying a lot of different things as opposed to trying one thing at a time, getting in early and making sure, you know, with Friedman, you know, he's a very hopeful guy. He's a very optimistic guy. He believes that he's going to be able to treat these tumors and let people live longer than they've ever lived before. And certainly I think that helps a lot as well.
Thank you.
Thank you.
Dr. Gupta, it was really fascinating to know about your work on cheating death or postponing death. I think one of the biggest heartbreaking things that happen is when fetuses arrive to the world dead. So have you done any work on, or have you come across any work on postponing death in the womb so that it doesn't arrive to the world dead?
Postponing death in the womb?
Yeah.
I mean,
for fetuses, for young babies when they're born.
Right.
Have you come across any work which postpones death in the womb?
You mean, so I understand, like fetal?
Yeah.
Types of, yeah, you know, I think I understand what you're saying, but I'm not 100%. This is a medical, not more of a philosophical question.
Yeah,
right?
it's a medical question, yes.
Just making sure.
As in you said you can pump chest, right, to postpone death.
Right. So, well, you know, there's a lot of things that are being done in the womb now in terms of interventions trying to take care of fetuses that otherwise would have had essentially deadly problems. You know, would not have allowed the baby to come to term. And remarkably, they're fairly simple problems. For example, if your heart's beating and one of the outlet valves from the heart, just basic plumbing, is blocked for some reason, the heart is eventually going to get large, called hypertrophic, and essentially won't work well. It just becomes a boggy heart that can't function well. And so literally, and you know, it's amazing to think about the type of surgery because you're talking about really trying to thread a catheter into a vessel inside a raisin, essentially the size, and opening up that outlet valve and allowing the heart to sort of pump more normally and as a result develop more normally. That's happening now. That's probably the best example of life-saving or preventing death type of procedure that's being done in utero. There's a lot of other procedures that are being done in utero. A lot of it's pioneered right out here in San Francisco at UCSF, but that's probably the best example of how you can actually prolong a life in utero.
Let me jump to a Dory question. Sanjay, what do you think about the trade-off between using statin, the cholesterol medicines, to keep cholesterol levels down and the chronic exposure to statins long-term versus the risk of having high cholesterol? The example given is, say, an LDL of 150 or a total cholesterol of 200.
Yeah, there are people in this country, prominent cardiologists, who believe that statin drugs should be in the drinking water. I am not necessarily one of those people, although I think the evidence is starting to mount that keeping cholesterol down does seem to be associated with living a longer life. For a long time, you couldn't make that statement. As obvious as that may sound, all you could really say was that if you kept someone's cholesterol down, it might decrease their chances of having some sort of heart event at some point. The real question people want to know, I think, is this going to make me live longer? Is it going to make me live a more functional, longer life? And I think the answer seems to be yes. What I think is tough to sort of figure out is lower always better? Some people may have a perfectly fine cholesterol that's controlled with diet and not need a statin medication, whereas so many people are going on statin medications even, you know, in their late 20s, early 30s now, teenagers even in some cases. So personally speaking, I have a very strong family history of heart disease, and I was told at one point I needed to probably think about statin drugs. And instead, I basically started to eat right and exercise, and I always tried to do that, but I did it more so than ever before. And you know, I'm 40 years old now, and I've never required a statin drug, so I try and avoid it as much as possible.
So you're from Atlanta, and the CDC is headquartered there. So hypothetically speaking, say an outbreak turns people into ravenous zombies. What does the CDC do?
What did you say, an outbreak turns into?
Say that an outbreak turns people into ravenous zombies. What does the CDC do?
Well, I don't know. You know, it's funny, there was this whole thing about this viral illness recently where it basically caused people to go into this, they looked like they were dead, but they were actually alive. It was this trance-like state. And they found that it was this virus, essentially like a sleeping sickness sort of virus. And I don't know what the CDC would do necessarily, but I think that, you know, it's really hard to sort of communicate between public health groups in this country to try and figure out how they would, you know, try and take care of something like this. You know, when Google did this whole thing on the flu, for example, you know, when the was it avian flu, I think, or was it H1N1? I can't remember. They were basically monitoring
H1N1.
Monitoring searches and trying to figure out where there might be clusters of cases. And I think, you know, the biggest thing from a public health standpoint is trying to figure out when a infectious disease has actually made its way into the country, and is it starting to spread in some way. But don't know enough about zombies or to answer. Yeah.
Oh, thanks. Actually, I wanted to ask you a question on behalf of my father. He's a radiologist, and he gets really excited when he's able to see technology and medicine come together. So when I download an app to show X-rays of his patients in 3D or things like that. So how could you imagine technology continuing to advance the world of medicine, especially as a neurosurgeon? How would you see that moving forward?
Technology advancing?
Mm-hmm.
You know, I think most of what's happening, frankly, is going to put neurosurgeons like me out of business, which is probably not a bad thing. I think because for the patients, I think it'll be a good thing. The operation that I was just showing you, which is the type of operation that I do, it's already starting to be done in lots of different ways, including doctors actually being able to thread a catheter all the way up into that blood vessel and essentially fill that aneurysm, which you all just saw, with coils. Basically, these small coils that essentially cause sort of the aneurysm to scar and not get any blood into it anymore, so you don't have the risk of rupture. That's already happening. Tumors are being treated now without surgery. Some have said that most of what neurosurgeons are going to be needed for probably 10, 20 years from now is trauma. People not wearing their seatbelts, hitting their heads on windshields, which is what we end up taking care of a lot. You know, patients actually going through a windshield on a freeway and coming into the emergency room. So I think the same can be said of general surgery, orthopedic surgery, and probably most of medicine in general, that it's going to become less invasive, probably more reliant on people like your dad, frankly, to take care of the same sort of things that we took care of.
Do you think that Google could play a hand in that in any way?
Do I think what?
That Google could play a hand in that in any way?
Yeah, because I think patients are going to demand it, and they're going to search for it, and if a lot of people are searching for a minimally invasive way to take care of an aneurysm, I think that's going to drive people to get better at that, to improve the techniques, maybe improve the resources towards developing that technology. So yeah, I mean, I think the people can speak through Google. I think that's what I would say, and I think that's probably the most true in health and medicine because it is so ubiquitous. It has the common denominator is obvious. Everyone's affected by it, and I think that's maybe how Google helps.
Thank you.
We'll take one more question here, and then I'll ask you a last one.
It's going to be a zinger?
No, it'll be easy.
Okay.
I was wondering about how long have you been able to keep someone in suspended animation, and how long you think it would take for suspended animation to be implemented in hospitals around the country?
Yeah, you know, I'm glad you asked that because I was absolutely fascinated by this. You know, as far as we know, no human being has ever been in suspended animation. And I say that because there are some scientists around the world who claim they have already done it. Impossible to verify. Mark Roth, who I was talking about, is probably the preeminent guy in this country working on this. And he's done only animals so far, including mammals. They've done for over a few days. They kept animals into suspended animation. And again, keep in mind what we're talking about when we're talking about this. Basically, your body is completely shut down. Your heart's really not beating anymore. Kidneys aren't filtering anymore, your liver's not working, your brain is not getting any blood flow, nothing is really working in your body. When they did this in developing fish, for example, they would suspend the fish from day 2 to day 5, for example, and when they reanimated at day 5, the fish continued to develop as if it was day 3. So they literally suspend everything in that interim period. The goal is, to be able to suspend people for over a day, to get them back to some sort of definitive care. Again, in the scenarios that I was describing, whether it's a soldier wounded somewhere overseas, or it's somebody who finds himself in an avalanche or near drowning or something like that, to be able to suspend them as soon as you find them, it's buying that time. And if you talk to Mark, he says it's absolutely possible, it's absolutely going to happen, and he thinks it's going to happen within a few years.
So is there an element of cooling involved in that, or is that something you could apply in the field?
This is different than cooling, although hypothermia is a good example sort of the same thing. Hypothermia basically is slowing down your metabolism as well. So like I said, you can do one of two things. You can either increase the amount of blood that's flowing, or you can decrease the demands. Hypothermia decreases the demands. With suspension, you're basically stopping everything. You're stopping the heart from pumping. You're stopping any demand at all in the body. The body requires no oxygen. The concern is that all those cells would die if you didn't provide some sort of alternative fuel. So they give the ketones just to keep the cells alive during that suspension. And it's sort of the same paradigm. The thing about suspended animation is that it could probably keep people in that state much longer than hypothermia could.
Thank you.
So I'll take the liberty of asking a last question. In light of the way many of us think, and one of the previous questions, how do we use technology to improve health? How do you balance the desire that so many of us have to find, the way to do the next generation of robotic teleneurosurgery, or whatever the case may be, with the incredibly basic needs that you see in some of your work, for example, in Haiti and elsewhere. And how do you, any guiding words for us to think about how to try to solve both kinds of problems without total cognitive dissonance?
I've thought about that a lot this year. You know, I was in Haiti several times, and in Pakistan for a long time. And it's unbelievable, you know, as I said, I think in the talk that you heard in San Diego when I was talking from Haiti, that given everything I've talked about today, I've seen people on their hands and knees for a glass of clean water that could literally mean the difference between life and death for them. There is a lot of dissonance there, and I think you don't want to ever sort of impede progress because of it, but I think that, you know, sometimes there's overlap. You know, clean water in Haiti, some of those problems, some of those issues could be addressed by better technology, frankly. Getting clean water filtration systems into areas all around Port-au-Prince, that could really help. So, you know, I think there's a lot of people who are, you know, really smart, they're entrepreneurial as well as technologically savvy, who do think about those basic issues and how they haven't been met despite all the advances we've made around the world. So, you know, I don't know, Ronnie. It's a really good question, and I wish I had a better answer to that. But I think that you know, I look at a guy like Dean Kamen, for example, and think that he could potentially, through a simple invention, save hundreds of thousands of lives by simply getting people clean water that they haven't had in a long time. But I think that, you know, I would be hard pressed to say that anything should impede progress. I don't think these are mutually exclusive things, that somehow you have to stop progress to be able to save people who are in need of basic things. I think you can do both, and I think we should everywhere around the world.
Huge thanks for coming here.
Thank you very much. Thank you.